the document from the EC about recommendation practices for data standardization. And I copied one, it's a very thick report, and I copied this one. Collecting data in a standardized manner will allow it to become synthetically and semantically interoperable. And the term interoperable will be discussed later on. It basically means that we can combine databases, that the database is set up in such a way that not only the database program, but also the content are exchangeable between databases. And at the moment it's so that there is no database available in the world which is interoperable. ERN should consult rare disease fair data linkage specialists to discuss their specific needs. Now that's basically what we did by inviting Marco here and also making part of our working group. And I think also the advice is to become part of the Go Fair. We already did that. That's basically this reference. There are many issues, and just a small list of what's been mentioned by many. Time. Who's going to fill in the database? If you are on a consultation with a patient, do you have the time to do that? And I tried it once when we had a database, but it almost took me 20 minutes, and you only have 30 minutes for time for consultation, so that's a big problem. Then the money, who's going to pay for it? Control issues, privacy issues, exchangeability of data, local rules, because we know that we have European standards for about exchange of data, but it's often so that hospitals do have their own rules and do not permit you to export data. So we got to take care of that. Publication rights, maybe later on, might be important. If we got a huge database, who's going to publish from it? Who's going to take the rights from it? And for some people that's important. And then, of course, why should we start a large database if we don't have a sufficient research question? First come up with the question and then come up with the database.
Sorry, I think there's another important issue. That's a liability issue, because if someone hacks into the system, who is liable for that?
Correct. Correct. Or you can fill the list with a lot more of issues if you want. Yeah. Okay, so basically what we did, I already showed it this morning, we had a technical subgroup with Marco, Christian, Jerome, Dirk Arts and Holgar. We're part of the steering group, COVRA. This is just a small thing from VASCA that we tried to set up a patient signal bank together with the patient organization. And if that comes, something useful come out, we can basically share that with the others. This is an important one. We've just been asked for that to join, this VASCERN to join that in the consortium. And it basically could give us some clues of how to skin this cat. Yeah? So my first question is, are we all in agreement that we're going to join this?
Can you tell me what FAIR stands for?
We'll come later, but somebody will talk about 45 minutes about that, so just a few minutes later. FAIR is findable, accessible, interoperable, and reusable. Does it help? Marco will tell you later about that. Yeah.
So, to answer a question,
Okay.
Is there a reason to say no?
Could we have a bit more information about what will it involve if we sign up to this?
Yeah.
So the question is, are we then going to be expected to attend lots of meetings, to spend lots of time generating issues? In principle, I think we all think it sounds excellent, but we have the issue of limited time.
Yeah.
And
Well, we got the complete proposal. I'm not sure if we can already spread that around the members. Can you say something about that, Marco? Oh, it's not working?
This is the other one.
So I'm not the coordinator of this project, so I should ask their permission to share documents.
Yeah.
But this is an IMI called Innovative Medicine Initiative, and that is always a combination of pharma and European Union funding. I guess people who are more involved with European funding can correct me when I'm wrong. And the ambition is to, how do I say it, make the data of 100 million patients interoperable. And what I've done is in that I'm part of that consortium through our national organization and also The Radboud University is also part of that national organization. What I've done is to make a case for rare diseases in this consortium. So it will be about many diseases, but also rare diseases. And I put forward to have this ERN as the one of the main cases in this proposal. So, and it will basically work on implementation of fair standards, tools and guidelines and building trust and everything there. I should mention it's fierce competition in this grant scheme. So no guarantees. I think what is good to know that even if we don't get it, then another consortium will get it who will have to develop technologies and guidelines and tools so that they can address 100 million patients. So also when we find out who won, if it's not us, then we'll start bombarding them as well. But here we have a chance to really put this ERN in our needs in.
Yeah.
So should we, is there a reason to say no?
I don't think so, but unless everybody wants to build his own registry, that might be another thing. But
so it's just a format, but you
exactly,
adapt.
yeah.
So there's actually some this is IMI, so they often prescribe things. So there is something called the Odyssey project. What they call OMO format, and which basically is conceptually implementing FAIR. And we looked at it, and it's something we can work with, and it's probably relatively good to adopt for medical institutions, because that's where it came from. So
But the trigger word is implementing FAIR, because that's basically what we're looking at. Yeah. Okay.
So, from I can say what I think. I heard already Marco speaking at the board in Brussels, and about the fair. He will make the talk, and we can take the decision after that. But I think everybody will be convinced by his talk and the work that Leo has been doing.
I think we'll do most of the work. Yeah.
And they are very interested in what they do. As you can see, Leo has done a lot of work with the others, and I think it would be a shame not to take advantage of it. And so my argument is a strong yes.
And I will use it the other way around. So this is a consortium.
No, you're strong no?
There's no, sorry. No, there's multiple interests within this consortium. So if I hear a clear yes from this group, I can tell the coordinators, well, we have a very eager group. We should put them at high priority.
So we are going to vote to have a strong yes or not a strong yes. Who is for yes? Can you call it strong? Okay, so yes.
Okay. Okay, now to go back to the plan, it's basically a bottom-up approach. What we already can do is start with local registries. Yeah, so the registry stays in your hospital, but, and that's the issue, the database program you're using and the database content has already to be fair. Yeah? Basically means that if we start with a minimal data set, and later on we can add additional items. Because it's fair, it's very easy to add things. Now about the minimal data set, I know some of the working groups have already been thinking about that. The European community came out with a proposed minimal data set. That's last week. That's this one. I was also mail it around.
There are 2 pages. Huh?
2 pages, yeah. Didn't fit, yeah. And I can tell you the items are almost completely different than what I've thought of. So this is basically our starting point. This is the minimal data set they required, and the question for the working groups will be, do they want to add some additional points to that? And this is what we're going to put in a local registry, a fair-made local registry, and the content being fair. And this is what is basically our starting point. And then later on, with the help with the IE2 concept, we will further extend on that one.
There is a second page. Huh? There's more than just these items.
There are 8 items on it.
Okay, there are 8 items, and yeah.
And
I'm going actually to show that
besides the list, there's also a clear statement that the data has to be interoperable. So already EC is already looking forward to the future.
8 items, but
I show them to you.
questions.
I show them to you later on the report on IT.
Can you show it?
The next one,
Yeah.
you mean?
No, that's not. No, I only got one.
Here.
This is the second one. So it's age on onset of disease, age at diagnosis,
I wasn't
diagnosis
too
of the
pleased with it
disease.
because already a lot of items. But this is not longitudinal, so this is only for a new patient when he comes in. And a lot of the questions is there consent or is the biological sample can be answered very quickly, I think.
So in terms of usability, if you look at 6.2, the genetic diagnosis, that just says they have a genetic diagnosis. That means if somebody goes into that database, they then have to go and contact the specialised centre. That means more work. Is it not feasible to include the genetic diagnosis within this, or is that going to breach major confidentiality issues?
Yeah, but
Because in terms of workability, we don't want to be having a list that we then go and contact somebody else to get somebody else to go through their databases.
yeah, but this database stays local. This doesn't go to a central database.
So my question would be how this doesn't seem to provide the data that we would need for it to be useful, if that makes sense. So say we wanted to go into a clinical trials and we want to make sure that we have enough people with the right genetic diagnosis to be in subcategories, so we can say which genetic subgroup respond in a certain way to a particular treatment. This would not give us the opportunity to go in and say we will randomise 20 patients who've got disease X due to mutation.
Absolutely
gene
agree,
Y.
but
So it's almost not enough, and yet it seems an awful lot.
Yeah, but it basically means this is the set, and if you want to have additional things in it, like you said now, you have to add that to this.
Can I just add something? This is something that I've been thinking about recently. The reason is, we can learn a lot from what the cancer teams have done. Cancer registry, for example, in the UK, is actually a registry where you all that it has is that it is cancer and that the patient has it. And essentially what we are talking about with this minimum data set is that, yes, this patient has a diagnosis of a vascular anomaly or a diagnosis of an iotopathy, and this is what it is, and there is a genetic diagnosis. No. But actually, they have done 10 years of research from BRCA1 patients, for example. All of that is done as separate collection of data, and they are even able to say what is your risk for, if you're a BRCA1 carrier, as to what is your risk in 10 years of developing another cancer, what is your risk of developing cancer when you're 80, for example. All of that is done as separate research studies by liaising with clinicians and patient groups as well, so that information can be collected. So there is large amount of data that we can collect later. But registries as such is where we go when somebody comes for a family history and says, I have a family history of aortic dissection. We ask them for death certificates to confirm that. But that is there. It's already there. You have 10 patients with that. And you can contact that clinician and say, you have 10 patients with that. Do you want to join the study? Sorry, I'm probably making it too simplified, but I was just kind of, we recently had a presentation about this in cancer, and I kind of thought, couldn't we follow that kind of a...
Again, this is not my idea. This is what is being proposed. Yeah.
What is not clear to me, we have the absolute need to not double or triple our work to record. So we are presently in Italy recording in every local HCP database, probably twice, because we have a research database and an official HCP database. Then we have to record the patients in national registry since Carlo 2006, more or less. So that could be the fourth one, or you can be able to extract from every national database existing the data you need.
Well, in the future, it's simple that basically your hospital information system will be linked to your registry, and certain data will be automatically put into the registry. But that will take another 5 to 10 years before it's there.
Excuse me.
I have a question. So this data stay local in the local hospital. So, like Elisabetta is saying, we also have a database since 2004. And if I look at this, that means I just have to add one column to my database?
Yeah, except your database has to be fair and the content has to be fair. Because otherwise we can't collaborate in the future.
I just wanted to add about the extraction of the electronic chart to the database. That the same problem is in France with a database which is called Maladie Rare, the Banque Nationale Maladie Rare, and they are in the way of solving the problem so that we can use, if I understood properly, our electronic chart and to feed directly the database. So it's possible, and I think the solution will not be in 10 years, more, but
it's already possible. It's already possible.
More early than that.
It's already
less than that.
It's already possible.
Well, I expect that in all the ERNs the same issues will be raised, but have you heard something on the coordinators meeting about these minimal data sets? It's basically been proposed and said by the EU, EC, this is what it's going to be. This is what you're going to have to.
This is not definitive.
So coming back to the problem of time, certainly we already have systems in the UK where data is entered once in the hospital system and then it can be extracted to pre-populate. But that has not been designed to do this, so I worry that it will be starting from the beginning for all of us. Mm-hmm. My solution or proposed solution in the UK, and I don't know if it's going to be taken forward, is that we put this in the hands of the patients who own their own data and who perhaps have the most time to enter a great deal of this, with us potentially just adding in. Because if not, the data set will be incomplete, because you can't expect a busy clinician to be also doing the 300, was it 300 minutes for the care of the patient in the system we had demonstrated this morning. That was a 300-minute. The duration of time allocated per patient is so limited that we have to find ways either to get other people in to do the data entry or to get the patients to do it themselves, because otherwise it all comes back to the same overworked clinician.
Yeah, I think that everybody agrees with you. And if one agrees more than everybody about that, this is Leo, who is very busy. And so he's taking this in his mind and is trying to work on the way to find a solution for that. But I'm just advocating for you.
Like you said, this is a proposal from the EC. It's probably going to be discussed, but maybe one or two items will be added or removed. But it's the same as to hold a large list which has to be filled out.
And the last thing I want to say about the minimum data set is that today or tomorrow, that will be the way that the EU is going to see the work we do. If we want or not, and probably there will be some funding depending on that. In France, it's occurring. It will occur very soon.
I just want to comment on this, because I don't know if it's now we have to comment on the way this data set is.
No.
But when we talk about genetic diseases, there may even not be an age of onset. There's only a genetic diagnosis, so you need to fill that in as well.
We can give that feedback back to the EC and see what comes out of it. Yeah.
If this is the way in which we...
No symptoms yet.
But if this is the way in which we are going to work in the future, you could use this as your primary data entry and feed your hospital system with it. Maybe that's more easy.
Yeah, that's probably the future. Yeah.
Always. But that will your hospital system also.
And if I understand it correctly, you're applying for funding to do this? So could part of the funding be to develop an audio system, because it is so much quicker to actually just be sitting there with the patient notes and just have some sort of audio system that would populate this?
It's a great idea, but I'm not sure if we got the funding for it, but it still is a good idea. Yeah? Okay, can we move on? Yeah? Oh, can I... Okay, this one is really important. So if we want to go, or anyway, the way to go for the small registry, local small registry, filled with a minimal data set, and we still haven't defined whether this will be this one, or whether it will be some added items. That's something which has to be decided in the RD working groups. Yeah. But again, I think there will be a minimal data set stipulated by the EC. Yeah. Oh, that's one. The second thing is we have the working group, the registry working group, and I really would like to have one contact person from each RD within that registry, so that he can act as a link. Yeah.
Okay.
Now, smart, small habit was already something we discussed, and this is an important item. Finances. I think we need to see if there are local data stewards within hospitals. And I know that every large university do have an IT department and probably have somebody targeted to deal with this kind of stuff. We need those names so that we can enter contact with those persons. Yeah? Second, is there some money available for the whole ERN, maybe a data steward, maybe for 30 or 40%, maybe, so that he can help out or act as an intermediate between centers? And I'm looking at you.